Well, hi, everyone. I'm Daniel Williams, Senior Editor at MGMA and host of the MGMA Podcast Network. We are back with another MGMA Insights Podcast today, and I'm happy to welcome Dr. Susan Montminy to our show today. Susan is the Director of Risk Management and Analytics for Coverys, and she brings a wealth of experience in patient safety, healthcare leadership, and risk management. And we're going to be talking today about a very specific white paper that was recently released, Hidden in Plain Sight, Exposing the Drivers of Diagnostic Error. I know that is an issue at medical practices that many of our listeners are steeped in and want solutions to that. So with all that said, Susan, welcome to the show.
Thank you for having me, Daniel.
Yeah, so I like to do this with any of these Insights podcasts and our other podcasts, just to get to know a little bit about who you are, your background. If you want to share that information, any highlights you might want to share before we get deep into those diagnostic errors.
Yes, thank you. I am a nurse. I hold a doctorate degree in organizational change and leadership. And I've been a nurse for more than 30 years. So I like to say that risk management and patient safety has been a part of my role for all of that time. I became interested in risk management after making a medication error. It was early in my career, and I'm sure listeners out there can relate to that moment when you realize you've made an error or you've missed something, that overwhelming feeling that you have. And I was lucky in this particular circumstance that no patients were harmed, but I started really paying attention to the importance of systems that we all work in day to day. And just as importantly, that we need to speak up when something isn't feeling quite right. And then as I started moving away from the bedside, Daniel, into more management type roles, here's where I started learning about the importance of teamwork, culture, communication, all of that, and how that relates to patient safety really became apparent to me. In one of my management roles, I was actually an employee health manager. And this was before it was really in the forefront of discussion in healthcare. And again, I saw firsthand that the individuals that make up the healthcare team, if they are functioning in an impaired capacity, fatigue, no matter what is causing the impairment, it just really affects the overall process of delivering care to that patient. And so again, that became important to me. So healthcare is a team sport, isn't it? So if one of the members are not functioning at their peak, care is going to be affected. So collectively, direct patient care, medication error opened my eyes to the importance of systems, culture, leadership, teamwork, emotional health for both the individuals and the entire team, and creating an environment where people can communicate and offer insights with each other. Just all of these things led perfectly to my more formal job description as Director of Risk Management. Most of my time, Daniel, was spent in a large academic healthcare system that had a level 1 trauma center. So I share that because I got to be involved in ethically, clinically, risk management, complex cases for my almost 10 years in that role, and the importance of the physicians involved in it and supporting them whenever an event happens, whether it's that retrospective look at what went wrong or that proactive look at let's design some systems that are safe so that we don't have error or things of that nature. And then finally, to my current position of Director of Risk Management in a medical professional liability company. And here, I moved from that organizational support, individual support, to what really excites me is that I'm able to share what we have learned through our clinical claims analysis with the healthcare community at large in the form of the white paper, which is what brought us here together today.
Yeah, I appreciate you making it personal and then expanding a bit. I really appreciate you sharing that with us. You mentioned a lot of things, so I do want to follow up with one thing. You mentioned the organization, Coverys. Tell our listeners a little bit about Coverys, who you guys are, what you do there.
Absolutely. So I'll begin with our mission.
Yeah.
Our mission is to support and protect the healthcare community. And we like to think of ourselves as very relationship-based. And I have to say to you that physician support is really a big factor in what we do. Just to let your listeners know, our board of directors is largely made up of physician and healthcare leaders, and our chair is a physician. So, we are all about protecting the entire healthcare community. The team that I lead, Daniel, is made up of risk consultants across the country with a variety of backgrounds and skills and areas of specialty, so that when we're asked a question or we are asked to weigh in on something, we've got this collective, I call it a brain trust, of all of the consultants who have really been where our policyholders are. They've been risk managers, they've been nurses, they've been pharmacists, they've been PAs, they are attorneys. And when someone asks us one question, we have the ability of tapping into all of the background and information and skills from the entire team. So I'm just really proud of what we do and of the team that I lead.
Yeah, thank you for sharing that. And I just want to say, I didn't know risk management could be so exciting. Your enthusiasm about it just comes through the Zoom lens here. So that's really cool.
Daniel, I wanted to dispel that myth of the stuffy suit-wearing risk manager. Where we are all about helping and supporting. It's why we come to work each day.
Yeah. So for people who have listened to the podcast, I've said this before, I love words and I love the play of words, so to speak. And so when we talk about this research paper y'all have been working on, it starts out hidden in plain sight. So when we're talking about diagnostic error, what are we talking about when we say it's hidden in plain sight?
Really great question. If I could, I just want to ground the audience in the definition of diagnostic error that we utilize. And then I'm happy to answer that question. We do use the National Academy of Medicine's definition, and that is diagnostic error is the failure to establish an accurate and timely explanation of the patient's health problem, or the failure to communicate that explanation to the patient. So just wanted to be able to share that. The reason we put hidden in plain sight, this is an area that we've got some really strong organizations that have tried to look into this and solve it. Think of Leapfrog and ARC and all of these organizations that have looked at it. But what we wanted to bring forth was a really deep dive into the clinical drivers beyond, we all know that, we have to communicate, but to really focus on some of the clinical areas that were most problematic, as well as some of the key pieces in that journey from when the patient first shows up and they enter the door of the emergency department. They might spend a great deal of time with us. And what does that diagnosis look like when they leave the emergency department? So hidden in plain sight is some of the things that were emerging from our analysis were fairly obvious, but I'll bet really not talked about and thought about in individual organizations. So I'm glad you like our catchy title.
Yeah, so let's talk about it then. One of the things I saw here, I made a note, one key finding from the report is that 28% of diagnostic error events occurred in the emergency department. It's fast-paced. There's a lot going on. There's trauma there. There's just a lot to deal with. Talk about those different factors that occur in that ED where people can make diagnostic errors. Talk about what is conducive to it, and what did y'all see through the study and through your work?
Absolutely. It's our hope that listeners download the paper and perhaps they already have it in front of them. Either way, if you take a look at page 5, we spent a great deal of time trying to depict pictorially the messaging that we were sending out within the report itself, and it's a tornado. So I ask you, Daniel, yourself, and any of the listeners, whether you spent some time during your training in an emergency department, perhaps you worked there, or simply you were a patient or a family member or someone in there. It is just this controlled chaos, is it not?
It is.
And when you're watching, back to that image, this buzzing beehive of activity that changes minute by minute, second by second, based on volume, based on patient acuity, is this constant shifting of priorities that has to happen already in this unique environment. And that lends increased complexity to the already complex activity of making a diagnosis with a patient that you know nothing about. They are brand new to you entering into the emergency department. So when you look at that picture, some of the key things that it talks about, and it's fraught with potential risk, and some of the key things that it talks about is the importance of communication, documentation of what you found. And I can drill down into that a little bit further, because it's not enough to just document it. It's the system of how the user is able to find what was documented. Really sitting in front of that computer screen and seeing this key vital sign that just changed, or this key lab result that just came back in that could totally shift the diagnosis path that the provider was currently on.
Mm-hmm. You use the term controlled chaos. So let's just take one more step into that so we can understand it a little bit better, because the chaos does exist. I've never worked in that field, but I have been a patient, unfortunately, a couple of times in an emergency department there, in an emergency room, and I see the chaos that's going on there and the stress that it can cause to people. So how do we get a little bit of that control into that situation?
Really, really great question, and so key. It's really about leadership, organizations, systems, and culture, all sort of embedded into one. And let me further explain that. And so the controlled chaos is something you can feel. It's tangible when it's controlled. And this is that team members are talking to each other. We do risk assessments as part of our role here at Coverys, and we get a feel as soon as we walk into an organization, a unit, a department. And you can't help the chaos that happens in an emergency department, but you can control it. And so what I mean by controlled chaos is you don't see the look of stress on individuals' faces. You see them, moving at a fast pace. You might see them even running at times, but they're talking to each other. Things are set up in such a way, there's not clutter. Things seem to have their place. And leaders are rounding, and they're rounding. And why they're doing that, they're taking a pulse check. Mm-hmm. They're making sure that this controlled chaos has not turned into simply chaos. And that is when you're going to see, like I just said to you, the stress on the faces. Something is different. Something has changed. And so it's switching. What does my team need at this moment? Maybe it's volume. Maybe I need more staff. Maybe there's a really complex case that has just rolled in the door that we really need to gather some other specialists and support the individual who is trying to figure out what is going on with that patient. And then finally, at the other end, if that chaos is not controlled chaos and there has been an event, it's that emotional support after the fact, and not asking, would you like, to really talk to somebody? It's coming over and saying, wow, that had to be really difficult for you. Let's talk about it a little bit, and just removing that person from the environment. Back to my earlier comments about how every member of the team has to be functioning at a good place to affect patient care.
Okay. One of the things that stood out to me from the paper is another term that really caught my attention. It talked about diagnostic bias. So let's define that, and then let's take a deeper look into diagnostic bias and what role that plays in these diagnostic errors.
Sure. I'm so glad you teased that out from the report. Bias is not a bad word. We all have bias, right. And so we actually stress that the single most important thing that health professionals can do is just recognize that they have it. It's this ability to question somebody if they've anchored. I'm going to give examples of two kinds of bias that emerged in our clinical claims analysis and in some of the accompanying stories. But just really recognize that we all have bias and develop some systems to be able to ask that question. Could bias be, at play here? What are our thoughts here? And really not becoming defensive if that question is asked, to really just go, wow, thank you for asking me that. Let me think about that for a minute. I want to bring in a study that there was over 3,500 ED cases that were analyzed. 32% had an element of bias in it.
Wow.
In the diagnostic error world. That is a number not to be ignored. Mm-hmm. And so let me bring the two key types of bias here. And the first one is anchoring bias. Okay. And I don't want to assume that all listeners know what this means. So let me just explain that this is the tendency to really lock on to certain findings in that patient's initial presentation too early in the diagnostic process. So I just described the chaos. Yeah. You have brought forward the fast-paced, ever-evolving environment. Can't you see how that might be an easy thing for anybody to do? Mm-hmm. It's I know what this is. I've seen it before. It's this. So let me pause there for a minute about the anchoring. That's why it's so prevalent in the ED, the unique environment. Now, let's talk about confirmation bias. So this is where I've made my initial diagnosis, and now these pieces of information that are coming my way throughout that journey are confirming, yep, I knew that's what it was. Yep, this confirms this is what it is. And I'm discounting unconsciously, of course. I mean the utmost respect to all of the physicians that are out there diagnosing in this fast-paced environment, that this unconsciously is happening. And so you need somebody to be able to say, hey, boy, this seems like an important thing. Have you considered that this might change the clinical picture?
Yeah. Wow. Okay. So when we take that information, I want to go to something you mentioned earlier and how important communication is. It's communicating whether a bias is occurring, whether it's involved with a handoff from person to person along the ED. Talk about communication and how guardrails or processes can be set up so communication is clear, concise, everybody's on the same page, and that chaos can get just a little bit more control around it.
More controlled. Again, yeah. that tornado image. Tornado image. Sure. Let me give one example that many organizations are beginning to try, and they're formalizing the communication, and they're calling it a diagnostic timeout. And so many are used to the timeout that happens before, a surgical incision is made, before they're proceeding with surgery. And that's just to make sure that everybody in the room is on the same page, before that happens. Why did that timeout process get developed? Because there were a lot of errors that were happening before that. So this is the same thing. This is just a diagnostic timeout. It's just, calling in a couple of colleagues to say, all right, what am I missing? And actually just asking that maybe I am missing something, and just having a conversation similar to what you do before a surgery. That's just one specific example. I'll step back a little bit more about the communication in general, because, we at Coverys, as I mentioned, our team has all worked in this environment. So we're not sitting here in our offices saying, well, you need to do this and do that. But there are things that can be nurtured in the environment and within the systems. And I like to call it walk a mile in my shoes.
Right.
So, this is not on the individual position. This is the onus is on leadership. And whether it's the IT leadership, with the risk leadership, quality leadership, in partnership with physician and nurse leadership, and really looking at how we communicate and how do we make it easier. And what's the main source of communication? The electronic health record. So, we really have to look at that. We get a box of information in the high-paced, noisy, multiple interruptions that the ED affords. Right. How can we make it easier to ensure that key pieces of information are pulled in to the individual user's view? So important. And again, sit with the physicians, follow them around on a single shift, and then go back. What you found from that, redesign those systems to make it easier for the user. Because despite everything else, it is better to have a conversation, and that should happen. Reality is, recognition is that the EHR is the main source of communication.
Okay. I have a final question for you. So, looking ahead, what can we expect out of diagnostic errors? I know that we have this thing called AI that's been tacked on to a lot of different platforms and apps and other things. There's other processes that can be put in place. So when you get out the crystal ball, I mean, you study risk, you work in that field, so you project, you see what's out there. So talk about what you see unfolding in this field as we move forward.
Absolutely. And I'll just start with a little stay tuned for listeners. Okay. We are going to be, it's important to understand that diagnostic error looks different in different environments. And okay. That's that hidden in plain sight title that we came up with for the ED. But we will be looking at the ambulatory as well as hospital-based settings. So, the things that emerge are going to look different than what we're talking about today. But mentioning AI, we in risk management, we love and hate it, and we love it because of all of the things I've already shared. AI absolutely has a role to play with gathering disparate pieces of information, all of these floating things that are important to the person that is making the diagnosis. AI definitely has a role to help figure out how to pull in those key pieces of information. So there's that. But the question is that we want to make sure that we're not pulling in so much that we then overwhelm, the person that is trying to function in this fast-paced environment. And I do believe that this diagnostic timeout concept is really going to start to take hold, just like the timeout in surgery, which is now, it's strange not to have it. My hope is that the diagnostic timeout has a similar path.
Dr. Susan Montminy, thank you so much for joining us on the MGMA Insights Podcast.
Oh, it was my pleasure. Thank you so much for having me.
Yeah, so everybody, we are going to put this research paper, I want to get the title right, Hidden in Plain Sight, Exposing the Drivers of Diagnostic Error. We are going to put a direct link there in our episode show notes. We're going to provide some other resources as well, so you can get some best practices put in place in your practices and be able to handle that better. So until then, thank you all for being MGMA podcast listeners.